Harriet, and I'm here with Dirk and Frank, and we are here to discuss the remarkably executed decision trial on ESC TV. Welcome, Dirk. Welcome, Frank. I wonder if you would start off by giving us a high-level overview of your trial results, Dirk.
Well, thank you very much. Well, as we know, the digoxin is the oldest drug in cardiovascular medicine that's still used by millions of people around the world. There was a big trial in 1997 with 6,800 patients in the United States called DIGE. That trial had as a primary endpoint all-cause mortality, and that primary endpoint was not met. Yet, at the same time, there was a 28% reduction in heart failure hospitalization, which of course is very significant. And if you combine the two, and that's what we do these days, when we combine death and heart failure hospitalization, it would have been significant too. So that was only against the background of ACE inhibitors and diuretics at the time. Now, a few years later, there were some sub-studies suggesting that high doses would not be beneficial, in fact toxic, but low doses would be very beneficial. But that's never been studied. And of course, since then, we've got a lot of new drugs for heart failure. You know, patient improved, got much better, drugs were very effective. But people are still thinking about that. So about 10 years ago, we developed that idea and we said we need to do a prospective, placebo-controlled randomized trial with low-dose digoxin. And that's what we did in the Netherlands. So we enrolled 1,001 patients, started enrolling in 2020 and finished the study end of 2025. So that's the story.
So a relatively small trial. What were your findings?
So we aim to have an event rate of 18 per 100 years. We got 19.3. So the trial was in fact looking at the population where it was supposed to look. There was a 19% reduction in events and clinical endpoints, CV mortality, heart failure, hospitalization. That, however, was not statistically significant. And that was due to the fact, because I think the power calculation was okay, but we did have some dropout of patients, about 20% of patients. That was due to the COVID pandemic. We made some calculations, and also because it was an elderly population. If we would have had a 1,500 or 2,000 patients, it would have been statistically significant, but that was impossible to do in the Netherlands, given, I mean, we had 43 sites, but it would have been impossible to do within a reasonable amount of time. So.
An important trial. Frank, what are your thoughts on the implications and take-home messages in clinical care settings?
Well, you know what my conflict of interest is? I love sports.
Okay.
And the great stories in sports are comeback stories.
Mm-hmm.
And I love the underdog.
Mm-hmm.
And if you teach an old drug new tricks, that's one story. But if you just dig out an old story, and I just mentioned dig out an old story,
Right.
which is a DIGE trial, in the end, you come out with remarkably consistent trials results. I don't call that a neutral or negative trial. It's what we discussed is an inconclusive data in decision. But first of all, they should be congratulated for doing a trial. It's an IIT trial for something probably other third parties wouldn't fund. And they pulled it through. And the results are pretty much in line with what we have seen with DIGE and Digit HF. And that's my story. I love a comeback story. And it clearly is. Yes, it is inconclusive. But when you put the data together in a meta-analysis, it's pointing towards the right direction. So I'm happy with the results. I love them.
Right. So a comeback drug that has had consistent demonstration of effectiveness now in HFrEF, remarkable results in rheumatic valvular heart disease, and then in the DIGIT HF trial, another demonstration of its efficacy. Where do you think the remaining gaps in knowledge are to foster uptake in clinical settings?
Well, that to me or to Dirk?
To you.
Well, when you put all the totality of the data points in towards the same direction, I think it is, for me, not a fifth pillar, but it is a wonderful welcome addendum to my armamentarium. I need some arrows in my quiver. And I think I have a lot of patients, particularly REF patients, who potentially will benefit from it. And I am absolutely convinced it is not just an AFib drug. There is a benefit, and Dirk, you correct me here from the data I look at. A patient with REF in sinus rhythm or AFib are good candidates for it. And we need more than 4 drugs.
Mhm.
You know, we've come a long way, but our patient, the residual risk is super high. There's no such thing as a stable heart failure patient. So there will be always a patient in need for additional meaningful clinical benefit. And that I've seen in the totality of data.
Right, and there's some patients who don't tolerate our core pillars due to hemodynamic effects, and they might be a
Absolutely.
group who benefits especially from this intervention. Congratulations on your trial and on the impact it will have in clinical care. Thank you, Frank, for being here to discuss the implications. And thank you to our viewers for joining us this morning.